Hello everybody. In this video series, what I have started is must know series. That is, these are short topics which you should not miss for revision. So I have thought in this way that if you just revise through these videos, these topics will be done for you. You'll just have to do another topic. Now for the today, it is basic principles of the surgery. So I'll be covering it in 3-part video. So starting with the first topic which I want you to revise is regarding the ebb and the flow phase of any injury if it occurs in the body. So starting with the ebb phase, it usually lasts for the first 24 to 48 hours, wherein there is total reduction of the metabolism, cardiovascular activity, everything. So the patient goes into the shock. That is the first 24 to 48 hours. Followed by the flow phase, which is divided into two, that is anabolic and catabolic. So the first phase is catabolic, which starts after the ebb flow gets done, that is lasting for 3 to 10 days after the process of injury starts, and the anabolic state, which stays on for weeks. That is also the phase of recovery. And the flow phase, that is a phase of catabolism lasting for days, and the ebb phase will last for first few hours. Now, second thing, this is a very important thing you need to understand. What is the turnover rate for muscle, liver, and about the albumin? So if you see that the muscle has a very small turnover rate of 1 to 2% per day, although majority of the body, so it has a large mass, but it has a very low turnover rate. Now liver has a very small mass, that is nearly only 1.5 kg, but it has a high turnover rate of 10 to 20% per day. So that is about the liver. Now coming to albumin, so it is a export protein from the liver. And what is the renewal rate? So the transcapillary escape rate, or the rate of renewal of albumin, is 10% per day. So that is what we need to understand. So whenever there is an injury occurring or there is any stress response in the body, usually if we see there is hypoalbuminemia, so that is not usually due to the decreased production, but is due to the increase in the transcapillary escape rate, because of it there is dilution, and so there is a reduction in the albumin in the initial phases of injury. Because if you see, this is the line, that is there is increased threefold following any kind of injury and sepsis. So that is about the albumin. Now another important thing about the mixed venous saturation in the body. So normal level is between 50 to 75%. So normal level is 50 to 70%. So if it goes below 50%, so either there is less delivery of O2 to the tissues, that is seen in either of hypovolemia or cardiogenic, wherein again there will be poor oxygenation and poor flow to the tissue. Coming to if it goes above 70%, so that is seen in sepsis. What happens is, in sepsis, the tissue, first, they are not able to utilize the O2 which is supplied, and secondly, there is reduction in the supply because of the septic shock, and also it is seen in patients having distributive shock. But if the patient is in sepsis and the level is not 70%, but it is between 50 to 70%, that means that there is associated hypovolemia. So in that case, we need to treat the sepsis along with the hypovolemia. So I think this is clear about the mixed venous saturation. I've covered this table, but in the tissue regeneration chapter, this is a very important table which we need to understand and remember. So starting with, what are the factors according to which we classify the various functionalities of the various tissue engineering and regenerative cells which are used in the therapy. So whenever we want to do any tissue regeneration, we need to have the cells available, so that is ease of availability. Second, we are doing in vitro expansion and then we inject it or implant it, so we need the expansion capability. we need sometimes a cell to convert into a certain type, so we need a pluripotency. It should not have any kind of ethical concerns. It should not have any high risk of malignancy. So this is, if you just label it as the ideal thing, what we need in a tissue regeneration cell, what we are using. And autologous is more better because of less immune reaction. And what is the future use of that thing? Is it available for only short duration, or it can not be used in a longer way? So that is what we need to understand and classify each cell. So if you see the somatic cells, they are very limited available. They are autologous. They have no risk of malignancy. They have no ethical concerns. They have no pluripotency. There is only one cell line which they can convert into, and because of that, it has a very limited use. If you see the inducible pluripotent cell, that is other extreme of the spectrum. So it is having a very good and excellent pluripotency and expansion in vitro, but the risk is about the malignancy. It has a moderate risk of malignancy. It has an ethical concern because we need to take the cells and we need to do a vector exchange for implementing certain genetic or transferring certain genetic factors into that cell for it to expand and to get converted into a different cell. So that is a risk. Ethical concern is involved, and we can take, because of this, that we can transfer through a vector, and we can certainly change the certain characteristic and transform into certain cells, or have autologous cell which can convert into a pluripotent cell. So it is autologous. So that is about the inducible pluripotent stem cells. Now coming to the second one, that is somatic stem cells. So it will have a limited pluripotency because somatic cells, they convert into a particular line only. They don't get converted into different types of lineages. As it is derived from autologous and somatic cells, it does not have any ethical concerns, very low risk of malignancy, and as I told, autologous, and they are at a high chance of use in future. Coming to the human embryonic, so if it is taken from the embryo, so there is a ethical concern involved, and because of that, we need, with the embryos can get wasted, so there's a very limited future use of this type of cell, and it is not all autologous. Risk of malignancy is obviously there, but only plus point is that it is a very good expansion capacity and pluripotency. Coming to fetal cells, now again it will have an ethical concern, risk of malignancy will be more, and because of that it is having a very limited use in the future, and it is not autologous again. But again, same, it is a good expansion but limited pluripotency. So this table is very important. If you don't revise anything in this chapter, just go through this table. So that will do your chapter 4, that is tissue regeneration. Coming to the infection, Southampton wound scoring is very important. They've asked a question in this. So obviously we start from normal healing and we go to a deep infection or a hematoma wherein we need evacuation. So remember, if hematoma is there, it is grade 5, and deep infection or like without or with a tissue breakdown, it is grade 5. From normal, if you see 1, that is divided into 1A, 1B and 1C. So it will start with just redness, that is, it will start with some bruising to considerable, to it will get converted to mild erythema. Now, if that erythema spreads along one point, that is 2A, if around the sutures, so not whole wound but around some sutures, that is 2B. So try to remember it logically. So there will be some redness, there will be considerable redness around the wound, there will be mild erythema of the surrounding skin, then that erythema with inflammatory signs along one suture, then around a few sutures, then there will be along the whole wound, only along the stitch line basically, and then coming to around the whole wound and surrounding skin area. So that is grade 2. Then we come to grade 3. So that will have starting of discharge. Now again, it will be 3A, 3B, 3C and 3D. So 3A will be 1 point, 3B will be along the wound. So at one point that will be less than 2 centimeter. If you see along the wound that is greater than 2 centimeter, then it will be a large volume. As it is a seropollulant discharge, it will be a large volume. Then it will be persistent or prolonged discharge, that is greater than 3 days. That is grade 3, and grade 4 it is pus, that is same at along the wound at one point that is less than 2, and along the wound that is greater than 2 centimeter. So if you see, and if you want to try to just remember it, you can remember it as 0 will be normal, then coming to 1, that will be around bruising or erythema. Then will be erythema along the wound or along the sutures. Then there will be clear or serous discharge. Then it will be pus, and lastly deep infection. So that is a Southampton wound grading score. Now this is a very important table which I have accumulated for you regarding the differences between hypertrophic scars and keloids. So hypertrophic scar basically occur whenever you have closed in lines of tension, or there is persistent pressure, or there is external stimuli. So it will be a hypertrophic scarring, the name itself suggests, but it can regress spontaneously if the inciting stimuli are removed. Keloids, basically it has a genetic predisposition and they grow beyond the borders. Usually the hypertrophic scar, they're limited to the wound, but the keloid, they grow beyond that. Then coming to the type of collagen, so hypertrophic scar will have a well organized type 3 collagen. Keloids will have a disorganized type 1 and 3 collagen bundles, and in both the collagen bundles are aligned in the same plane as the epidermis, whereas in normal wound they are arranged in a haphazard way. So that is important thing to remember, that in normal wound they will be arranged in a haphazard manner, where in this they'll be aligned along the same plane as the epidermis. Then in hypertrophic scarring, there will be a thicker abundant collagen bundles, like acellular node like structure will be there. In this it will be aggregates of fibroblast collagen fibers throughout the dermis. You can remember about the collagen and how are they arranged, and then causative factor already cover, wound stimuli and the genetic predisposition. Then this is important to remember, and both of them, MMP1 that is collagenous and MMP9 that is gelatinous, are decreased, and so there is no early tissue repair. There is collagen deposition leading to hypertrophic scarring or keloids. And MMP2 that is gelatinous, but it is associated with a late tissue remodeling, and that is elevated in both. So if you see, 1 and 9 is decreased, 2 is increased. So as 2 is more than 1, so 2 is increased, and 1 and 9 is decreased. So that is about the difference between hypertrophic scar and keloids. Now tropical chronic pancreatitis, basically it is a topic I've taken because they've asked a question which we may sometime miss in the chapter of tropical infestations and infection, because other than that we can still answer every question. So usually tropical chronic pancreatitis, it has familial predisposition. It is a younger patient, nearly less than 40 years of age. It is associated due to either malnutrition, dietary, familial or genetic factors associated with cassava ingestion, which leads to the pancreatitis because of the cyanogen involved in it, leading to cyanogen toxicity. If you see, because of the inflammation, it will be a firm and nodular pancreas with extensive periductal fibrosis, obviously because of the autoimmune type and familial involvement. And because of the fibrosis, there will be intraductal calcium carbonate stones will be there, and the ducts will be dilated. So dilated ducts, stones, and a fibrosed hard chronic pancreatitis like pancreas. If you see the microscopic, there will be fibrosis everywhere, that is interlobular periductal, that is a prominent feature. And there is also, because of the involved fibrosis, it can convert into dysplasia and cancer, so they have a high incidence of pancreatic cancer. Coming to diagnosis, patient usually presents with symptoms of pancreatitis, and also sometimes because of the fibrosis there can be fibrocalculous pancreatic diabetes, or they can present with either exocrine or any kind of endocrine insufficiency. and usually they have a serum amylase in the normal limits. Imaging, usually like MRC, chronic pancreatitis, we can evaluate on the basis of CT, MRI, or ERCP, which can help in both diagnostic and therapeutic intervention. Treatment usually medical for the pancreatic insufficiency, be it endocrine or exocrine. Pain, for that we'll give painkillers, and surgical treatment if there is a sign of intraductal hypertension or the pancreatic hypertension like chronic pancreatitis, which will present with chronic pain and chronic insufficiency. So for the pain, usually we do surgical decompression of the pancreas. So that is about the treatment of chronic pancreatitis in tropical chronic pancreatitis. Coming to the surgical site infection classification, this is very important. I am just covering because you need to be aware about it. So starting with superficial, deep, and organ space. Usually all of the three include that a physician should diagnose it either by like opening up the wound or by the culture taken, which should have a, so like diagnosis depends that a surgeon or a physician should do it. It should have a positive bacterial culture, either opening of the wound or there should be spontaneous opening. There should be signs of inflammation. Then only you can diagnose it as a surgical site infection. Now coming to what is superficial, what is deep, and what is organ space. So if usually all of them occur within 30 days after the procedure, in superficial it involves only the skin and subcutaneous tissue. Deep, it involves other than the skin subcu, that is soft tissues including facial and muscle layers. And lastly, organ space. So that includes that the pus or the discharge which is coming should come from a deep organ space, that is any part of the body excluding the ones which I've already told, like skin, subcu, soft tissue, facial, muscle, facial or the muscular layers. So that is what is organ space infection. And as I told about the criteria, I can just sum up as I've already done. That is, there should be pus discharge, the organism should be isolated, and signs of infection should be there, that is signs of inflammation should be there, and the incision should be opened by the surgeon for taking the pus if it is not discharging spontaneously, and it should be diagnosis made by the surgeon or physician. So that is about the CDC classification of SSI. Coming to the surgical wound classification. So if we have done a surgery wherein we have not entered into the respiratory tract or GIT or genitourinary tract, and we have primarily opened and closed the wound under proper aseptic techniques, that is a clean wound. So wherein we have not encountered any kind of traumatic or after any trauma. In clean contaminated, if we are entering into these tracts but under aseptic procedures, for example, as I told already, oropharynx, nasopharynx, biliary tract, appendix, all of them, and we have no break in the technique of asepsis, then it is a clean contaminated. Coming to contaminated, so any kind of open, fresh, accidental wounds basically with break in the sterile technique, or we have operated in a patient who is having perforation, intestinal perforation, so there is spillage of the intestinal content, but there is, other than that, there is no purulent inflammation which is encountered. Perforation is there, so there is gross spillage of the GIT, but there is no purulent inflammation involved, then it is a clean contaminated. And any kind of old wounds which have dead necrotic tissues involved and already the organisms are present for causing the inflammation or infection, that is dirty wound, dirty or infected wound. So that is about the surgical wound classification into clean, contaminated, contaminated, and dirty. Now, what are the signs and symptoms of necrotizing infections? So basically in necrotizing soft tissue infections, why I want to cover this, because of the certain points which are there which you should not miss. So that is a dishwater pus, crepitus, edema is there, and usually no fever in this patient. They present with clinical sign, but if they present with septic shock, they can have fever, but usually fever is not there. They just present with the clinical signs of edema, erythema. Sometimes the tissue is so necrosed that there will be a pus that is gray color, that is typical dishwater pus. There will be a focal skin gangrene, but it is usually late, and if they present very late, usually with septic shock features. So that is regarding the necrotizing soft tissue infection, and especially the dishwater pus. And if you insinuate the finger, there will be easy entry into the layers. So that is a clinical sign. Now, again, this is a very important thing, that is a surviving sepsis campaign guidelines for managing septic patient with a septic shock. First is always fluid goal directed therapy to maintain MAP above 65, not blind therapy of fluid, not blind IV fluid given to the patient. We should always give so that the MAP is maintained above 65. Usually that amounts to 30 ml per kg of crystalloid within the first 3 to 6 hours. Then if still we are not able to maintain the MAP, then we should start vasopressors. Even after the fluid and vasopressor, we are not able to do it, then we should start with inotropic like dovitamin. Then coming to blood transfusion, we should give if the hemoglobin is less than 7. And about the antibiotics and stress dose steroid, if required, then we should give them. So that is the first part, covering the initial topics from the chapters of both Bailey and Savitron regarding the basic principles of surgery. Keep watching this space. I'll be updating the next 2 parts in coming time. So just try to go through this. It will cover the important must-know topics which should not miss from this chapters. Thank you so much for watching.